In 2017, Michael Hickson suffered a heart attack that left him with physical and cognitive disabilities. In May, he caught COVID-19 at Brush Country, an Austin nursing and rehab home. At St. David's South Austin Medical Center, he developed pneumonia. On tape with Michael's wife, Melissa, one of his doctors there dismissed Hickson's previous quality of life when talking of discontinuing treatment. It would seem to contradict federal guidelines. In March, with coronavirus rising, the Department of Justice's Office of Civil Rights saw the potential for discrimination and issued a bulletin to medical providers. The bulletin warned, quote, individuals with disabilities should not be denied medical care on the basis of stereotypes, assessments of quality of life, or judgments about a person's relative worth based on the presence or absence of disabilities. Rather, decisions about treatment should be, quote, based on an individualized assessment of the patient, based on the best available objective medical evidence. In its statement, St. David said, quote, this was not a matter of hospital capacity. Hickson, it said, was in multiple system failure and regurgitating his food. Quote, it was not medically possible to save him. But it's enough to raise a red flag among the disabled, who have a history of secondhand medical treatment. On April 6th, advocacy group Disability Rights Texas issued a letter to Governor Abbott and the Commissioner of Health and Human Services, making them aware of the federal bulletin. It called on them to set statewide guidelines, like other states have in the pandemic, for equal treatment to all Texans and helping medical professionals in their decision-making. A number of disability groups and Catholic bishops had signed on, said civil rights attorney Lisa Snead.
Unlike many other states, Texas does not have statewide guidance that would apply in a pandemic like we're in now. As healthcare resources become scarce and decisions have to be made about who is getting access to what resources, it's important that hospitals have guidelines that provide for how those resources are going to be divvied out and who has access to them. Because Texas does not have those guidelines, it means individual hospitals or individual regions or doctors are making them up on their own. So each individual hospital could be following something different, or hospitals in a certain region like Dallas could be doing something completely different than hospitals in San Antonio, and there's no consistency, right? So like a regional medical association in a city like Dallas or San Antonio can say this is what our members think is the criteria that we should follow, but just because this medical association in Dallas or San Antonio has said, hey, we think this is what people should do, doesn't actually mean that any given hospital or any given doctor is following those standards. So that's the other reason that it's incredibly difficult to figure out how these decisions are being made, who is making these decisions. And it is vital to understand how these kinds of decisions are being made, because people have a very real fear of dying. And if you know that you may get different treatment in one hospital versus another but not understand how that decision is made, it is discouraging people from accessing health care. In addition to being no consistency, many of the guidelines that medical personnel come up with on their own are discriminatory to people with disabilities. They provide objective framework that either does not take into account disability accommodations that are necessary, or they frankly, a big one is that they take into account things like quality of life, which is a huge issue because medical personnel, study after study, has shown that they consistently devalue the quality of life experienced by people with disabilities when compared to how those people value, or the people in the studies value their own lives.
Another one of the troubling things that you're trying to clarify here is, I guess, one of the the criteria that medical professionals always bring up is the expected lifespan after treatment is taken. For instance, that could discriminate against people with disabilities, but also the aged or people of color, correct?
Absolutely. When you take into account things like life expectancy, number one, the longer you get out, the more questionable that data becomes, right? When you're talking about 5 years, 10 years, the data there isn't terribly accurate, though we like to think it feels like an objective measure that you can put your hand on, right? And then as you identified, it absolutely discriminates against people who are older. And these kinds of things, yes, absolutely also then to start discriminating against people of color, because many different disabilities and physical conditions are more prevalent in communities of color. A lot of that also being linked to just the lack of health care that communities of color are also, the lack of access to health care that many communities of color already face. So when you start putting in criteria like expected life expectancy, that's nowhere near as objective as it seems.
Right, like they're supposed to make the decision at the point of treatment, right? Just whether or not treatment will be good for this particular candidate, and then make no further assessments on quality of life and their lifespan afterwards, correct?
Correct. You want doctors making the treatment decision based on whether or not this treatment is going to be effective. So even the disability groups are saying, you know, if the medical science is telling you that even if this person received this treatment, they are going to die in the very short term, no one is arguing that that person should be given, these very limited resources. And by short term, I mean this person is dying right now. After that, life expectancy determinations really disproportionately impact people with disabilities, of course, people who are older, and as you identified as well, people of color.
Okay. And what was the response to your letter? Did you get a response?
Cricket. No, we did not get a response from the governor. We did not get a response from HHSC. Really disparate groups around the state, as the pandemic has become worse, are calling for the same things, but we have not gotten a response from the executive officials of the states.
This week, advocacy groups won a major agreement with the state of Tennessee, which does have a statewide crisis standard of care. Curbed our exclusionary terms against treating people with disabilities and judging patients on their quality of life. I asked if the agreement might influence the state of Texas.
You know, and I would hope so. I would hope that a state like Texas would look at a state like Tennessee and see ways that they're similar, that perhaps even the political leanings of the government are similar, and recognize that Tennessee found it was necessary to settle and that these were the terms of the settlement, and so that if Texas were to develop guidelines, that would be a model to use.
Right.
Ones that OCR has already said, yes, we will approve Tennessee's rights. That would be an excellent place for Texas to start.
Disability Rights Texas investigates care rationing throughout the state. If you or someone you know think you've been discriminated against in care, visit disabilityrightstexas.org or call 800-252-9108. For the People's News, this is John Mohler reporting.